Hi, this is Tiffany McConnell. This is my article presentation for MI 390R, Fall of 2017. And my article is titled Computed Tomography Guided Celiac Plexus Neurolysis for Intractable Pain of Unresectable Pancreatic Cancer. Sorry, everyone. Big, huge, long title. We're going to break it down and go through it. But basically, we're going to try and treat some people who have, in the article, they're trying to treat people who have pancreatic cancer, usually very late in the game. They're unresectable, meaning that they're not going to be able to undergo a procedure to remove the tumor. And they're having intractable pain, meaning that they've tried narcotics, they've tried NSAIDs, they're not getting pain relief. So this is just something that we're going to try and do. It's not going to save their life, it's not going to cure their cancer, but it's going to significantly help with their pain, especially, as things become, closer to the end for these people. Pain is a big thing. All right, so on the agenda for this presentation is introduction, so I'll just kind of talk a little bit about the background of this. Celiac plexus neurolysis, what that actually is. The clinical assessment of these patients, so what criteria the authors of this article used to figure out whether these patients were even candidates for a neurolysis of the celiac plexus. And then I'll briefly go through the procedural technique. It's pretty in-depth. We're just going to kind of skim through the major parts of that. And we'll talk about the post-procedure follow-up, so how these patients were doing post-procedurally, immediately at 1 day, at 1 week, and at 3 months, how they were doing pain scale-wise. And then we'll talk about some of the results. All right, so the introduction. This is really cool. This is an image from my article, and I know not everyone here is medical, so I'll just briefly go over this. This is the aorta, the abdominal aorta, in the big red orange tube coming down. The yellow are ganglion or plexus, so they're the nerve bundles or nerve fibers that are wrapping around the anterior portion of the abdominal aorta. And then all those major nerve bundles are going to branch off, and they're going to go to the liver and the pancreas and the stomach and all these areas, all these visceral organs that allow you to feel things such as pain in a pancreatic cancer patient. And let's see if that pointer going to work. Yeah, we're on the TV. Well, we were thinking the pointer would work. But this is the celiac ganglion right here, or celiac plexus, and you can see it's got these little fingers coming off that are feeding, that's the bile duct and the gallbladder, and then you're going to have another one that's going off and feeding the pancreas. So, and pancreatic cancer is the 7th most common cause of death from cancer death as cancers go. And only 12 to 20% of pancreatic cancer patients are diagnosed at a resectable stage, meaning that only 12 to 20% are eligible to undergo a procedure, either a Whipple, which is a specific type of procedure, or some type of tumor resection in the pancreas. The other, 80% or so are unresectable, meaning that they maybe we can undergo chemo, maybe we can undergo radiation, but surgery is not an option for these patients. And that's typically because pancreatic cancer doesn't present with any symptoms. People typically don't know it until they're having abdominal pain, and they go into the ER with severe abdominal pain. They have a CT scan, and there's, this huge pancreatic mass. The pain is likely mediated from the celiac plexus. So that's the whole point in this procedure, is let's see if we can go into that plexus, let's see if we can block it, meaning inject some type of alcohol, some type of phenol, or ablate it in another way with a thermal microablation, cryoablation, something like that. The goal is to kill those nerve fibers in the hope that you can significantly reduce or even eliminate these patients' pain. And so I kind of already touched on that, what the celiac plexus, that's supposed to say neurolysis. Sorry guys, so just forget the C, that is supposed to say neurolysis. But again, it's just an ablative procedure that is going to attempt to kill those nerve fibers, try and get these patients out of pain. And the reason it's relevant to CT is because you use the live CT fluoro, so you use live axial CT images to guide in the probe or the Chiba needle into the patient. You have to have a 360. You can't just have, you know, an x-ray. You have to have a 360 degree to make sure you're not going off. There are several. You could puncture the small bowel, you could puncture the stomach, you could puncture the liver. There are several organs in that area. So that's why they do it under CT guidance. Make sure exactly where we need to be. And so this was one of the clinical assessments that they used, that the authors used before finding out if these patients were even eligible. They had several variables: age, weight, gender, onset of symptoms, location of cancer, which sounds odd because, well, wouldn't it be pancreatic? But so you have 3 parts of your pancreas. You have the head, the body, and the tail. So it depends on where the tumor is actually located, if they feel like they're going to, if blocking the celiac plexus is actually going to get rid of the patient's pain. So there are some factors. And then, of course, if the pain is taken care of, you know, via narcotics or NSAIDs, then you don't undergo a procedure. So this is only for people who have tried narcotics, they've tried NSAIDs, they've tried everything, and they're still in a lot of pain. And this is the good old-fashioned, if anyone's worked in healthcare, this is the good old-fashioned pain scale, the VAS, the Visual Analog Pain Scale System. It's 0 to 10, 0 being no pain at all, 10 being the worst pain you could ever imagine in your life. And the criteria for those patients was a pain scale greater than or equal to 4. Which didn't seem huge to me, but then the authors go on to talk about is even at greater than or equal to 4, they were on a lot of medication. So if you're talking about you're on, you know, oxycodone, you know, high doses of ibuprofen or Toradol or, you know, morphine, whatever you're on, and you're still at a pain scale of 4, yeah, it's probably worth doing this type of a procedure in the author's eyes. That's how they justified that. And so, okay, little quick pre-procedural technique. So the patient's going to be supine on the table, on the CT table, meaning they're going to lay on their back so that you have access to their belly. The procedure site to be marked is about 1.5 centimeters below the xiphoid. Xiphoid is this little bony part in the bottom part of your chest bone. So they would come 1.5 centimeters below that and mark that. The patient's sedated, usually via conscious sedation, so Versed and fentanyl. In some instances they needed heavy sedation or general anesthesia to undergo it. But most time if they were just instilling the alcohol or the phenol, they could do it via conscious sedation because it's not an overly painful procedure to undergo. So they mark the site. They're going to instill some local numbing, some lidocaine into the skin to numb that up. They're going to put that Chiba in. And I'll show you guys some slides and some actual axial CT images of the needle going in. This is just kind of a breakdown of how the procedure works. So they're going to go in with that Chiba when they feel like they're in a good spot, or at least close to the celiac plexus. And keep in mind, he's doing like the doctor will be doing a live fluoro while he's doing this. So he puts the needle in a little bit, he taps a live fluoro, steps off, pushes the needle in a little more, taps a live fluoro. When he feels like he's in a pretty good location, the CT tech will come and do thin axial slices, 2.5 millimeter axial cuts through that area just to confirm that he's not off to the side, he's not too anterior, he's not too lateral, he's exactly where he needs to be. And then once they're in the plexus, the authors talked about they instilled lidocaine actually into it first to lessen the burning sensation of when the alcohol or the phenol, the ablation material actually goes in. And then some of them even put a little contrast to see it filling. They also would pull back on the needle to make sure they weren't getting anything, because it's a nerve bundle. You shouldn't be getting blood. You shouldn't be getting anything. So if they were up against something else, they might get some sort of flashback into that needle. So they did use that as a confirmation technique as well. All right, so here are our images. These are really cool. This is straight from the article. So that white shiny part coming up here at the top where that blue arrow is, that's the needle. So Chiba needles on CT they're very bright because they're metal, they're dense. so you can see what you're doing. So you can see he's entering anteriorly. This is the liver off to here. You can see a kidney spine, and then that right there off to the right side of the screen of the patient is the pancreas.
Massive.
Well, it is, and honestly, I'm not the best person on this, so and these are a little blown up, so we do got to keep that in mind. But this does look pretty big.
Mm-hmm. A lot of your side.
Yeah, it's a majority. And again, I don't know. This is patient 6'2".
Yeah.
Is this patient 5'1"? So is you'd have to. It's relative, but yeah, I agree with you. And then so that's the needle coming through. So I can't get up there, I'm too short, guys. But if you see the vertebra towards the bottom of the screen, that round part, right above it, that gray circle, that's the abdominal aorta. So then this little gray looking bundle that's wrapping anteriorly around it, that's the celiac plexus. Can you see?
These are the nerves here, wrapping around the aorta here.
Yes. Yeah. And so coming off to the side is actually something else too. Coming off to the side is something else we won't talk about. But anteriorly wrapping around is those fibers, and that's his goal. That's the, or I say he, it could be a she. But that's we don't discriminate. But that is the doctor's goal, where he wants the tip of his needle to be. And then so that was C, and then in D, look, he's even further. He's actually completely entered it now. And you gotta think about it, you're right on that aorta, so you don't want to stick that aorta.
Right there on that aorta.
It's right there on that aorta.
I can see that.
Yeah. So again, why CT guidance is of the utmost importance to do this. And then this last image, that's contrast that you're seeing. That's why it's so bright. So that's contrast probably after he's ablated or right before he's going to. I think it's after. I don't think they can put that in. I'd have to look back at that article and just double check on that. But I believe that is after. To make sure that nothing's leaking around. He hasn't punctured anything. Excuse me. Of course, I decided to get a cold the day of the presentation, but it's all good. All right. So, real quick, so immediately, I was talking about immediately post-procedure, 1 day, 1 week, 1 month, and 3 months. So what they did is they assessed these patients' pain scale. Remember I was talking about you had to have a greater than or equal to 4. So they asked them immediately post-procedurally, how are you feeling? Well, probably pretty good. They've had sedation, they've had pain meds, and we've ablated. So they're probably feeling pretty good. So then they look at 1 day, 1 month, and 3 months. And it was considered bad when the pain persisted with no improvement, and it was considered good results when the pain was lowered or completely gone. And their goal in all this, again, these patients are terminal. So we're not saving their life, but we're improving, through this procedure. Absolutely, improving the quality of life for these people in their last days, weeks, months, maybe years, but more likely days, weeks, months. And then just some quick results. So 22 consecutive patients who were suffering from that intractable pain were subjects of the current study. And they had, their immediate scores VAS scores were less than 2, which is great. And that was maintained up to 3 months after. So, that's really good. So overall, it showed to be cost effective because you're doing it percutaneously. You're not opening this patient up. It's a very low risk of infection, low risk of bleeding, because again, yes, you're right on that aorta, but you're using CT guidance to ensure you don't enter that aorta. And a lot of these people had some really good outcomes. So overall, and this article was from 2017, so this is from the Egyptian Journal of Oncology and Vascular Radiology. So this is pretty cutting edge stuff, and it was an original article. It wasn't an article review. It was original research. So this is some pretty cutting edge stuff. Hopefully we can, maybe bring that here, or maybe they're already pioneering it here. I just thought it was great because pancreatic cancer it's very painful, and I thought that was awesome that we could try and help these people. Anybody have any questions?
For those of us that don't work in healthcare, what is a Chiba needle?
Oh, a Chiba, Chiba. So a Chiba needle is it's just a long needle. They come in different lengths. They come in different diameters. But it's a percutaneous access needle. It has an inner stylet. So once you take the stylet out, the inside of that needle is obviously hollow. So you can put a small wire. You can put the alcohol, the phenol. You can put contrast. Get blood if that's what your goal was. There's multiple things that you can do through that. So it's usually used for like a type of biopsy or accessing maybe a bile duct. So some type of percutaneous access into the body. And it's usually used in CT, interventional radiology, and I think diagnostic radiology might use it a bit in fluoro. But normally you're going to see those needles in CT or in interventional. Any other questions? All right, thank you guys so much for your time and attention. And we're gonna pan out now, pan around, and I'm gonna show you my 5 people. Sneaky. All right, we got Chris, Becky, Tyler, where are you? Tabo, hey. And Scott, DJ Whitey.
Another Becky.
And the other Becky. All right, thank you guys so much.